Welcome to another edition of Your Health Matters with Dr. Benjamin Bryant, Chief of Staff, and also General Surgeon with Conneaut Medical Center. Dr. B, how you doing today?
Oh, can't complain. I can't believe spring came so early out here.
We were just talking before we went on the air that last night we had tremendous winds and thunder and lightning, which is very rare for this neck of the woods.
Yeah, in February.
Yeah,
Gee,
really.
yes, yeah.
But the snow is supposed to be coming, Doc.
Yeah, I can't believe we're getting out of the winter this easy.
No, I don't either. I see you have another guest with you today.
Well, it's amazing that Dr. Michael Brown, vascular surgeon with University Hospitals, was kind enough to make the drive all the way out here to be with us this morning, and we're certainly glad he did. Vascular surgery. Well, I'm gonna let him explain what vascular surgery actually is. The public may have heard that term, but what should they understand about what vascular surgery is?
First of all, thank you for inviting me.
Absolutely.
It's an absolute pleasure to come out here and give my 2 cents worth. So vascular surgery basically entails surgery of arteries and veins outside of the heart. Peripheral vascular surgery entails anything from carotid artery disease to abdominal aortic aneurysms, blockages in the legs that can cause pain when people walk. Other things that I do are dialysis access, which is obtaining access so that people can have dialysis.
Yeah, exactly. People who have kidney problems and who need to go on dialysis, that's basically a complete blood exchange. So you have to have a really good way of getting the blood out and getting it back in, and something that's durable and something that's going to give people no problems and be reliable and so on. And that's not something you just do. I mean, that's a very specialized thing that requires great attention to detail to make it work right. Where did you train?
So I went to undergrad at Case Western Reserve University in Cleveland, and then went to Des Moines Osteopathic Medical School in Des Moines, Iowa. And then came back to Cleveland and did my general surgery training in South Point Hospital, which is in Lawrenceville Heights. Then went on to Columbus, Ohio, and did a trauma surgery fellowship.
Holy smokes.
I thought that for a period of time that's what I wanted to do.
My goodness.
And then went on to Gainesville, Florida, the University of Florida.
Sure.
For a vascular surgery fellowship.
My goodness.
How long you been with UH?
I just came here in September 2015.
Oh, okay. Okay, great.
I was previously in Florida for 10 years.
And your offices are located?
So I have office in Geauga Medical Center on Fridays. Thursdays I'm at Concord Medical Center. And then Wednesdays I'm at UH Portage Medical Center, seeing patients and doing procedures.
Okay, very good.
Well, I understand there's some plans that you're going to be potentially seeing patients in Geneva.
That's in the works. I hope that in the next couple months that we will be seeing patients Thursday afternoons. We have plans to start what's called a limb preservation center, which entails a interventionalist or vascular surgeon, podiatrist, and a wound care surgeon kind of collaborating to decrease the amputation rates in diabetic patients. It's been shown nationwide that diabetics in particular have higher amputation rates, and the delay in their treatment is one reason why the rate is so high. So I had a limb preservation center in Florida, and we had a significant impact in our community. The primary care physicians loved it because they were able to give their patients they were concerned about, brittle diabetics, a place to go on a regular basis to have their feet examined and then if they had a history of any kind of a toe amputation or partial foot amputation, they're at an extremely high risk for another amputation either on the other limb or the same leg. So that gives the primary care physician and the patient a sense of security that you're having another layer of the medical community who specialize in preventative foot care.
Absolutely.
To look at them, and then myself as the interventionalist, if the podiatrist or wound care surgeon are concerned with the perfusion to the foot, then we can proactively intervene and try to increase the perfusion to the foot or leg.
Well, this is huge, folks. If I'm sure a lot of people listening out there have diabetes or know somebody who does have diabetes and knows the kind of problems that they can have with their feet, the infections they can get, and so on. And if there's going to be access to this kind of expertise, I mean, what's it worth to you to avoid having your leg cut off? I mean, how important is it to you to not have your leg cut off? I mean, that's huge, obviously. It's an enormous thing. And so what Dr. Brown is talking about here is that sometimes, despite what the podiatrist does, despite what the wound care specialist does and the infectious disease people and so on, there's just not enough blood getting down to where it's needed. And sometimes that's because of a problem that he can fix and certainly help with. And that's the difference between saving a limb and losing it. So that's very exciting to hear that kind of thing is going to be available to our public, to our town.
Yeah, we are planning to start having office hours once a month in collaboration with Dr. Milliman at Geneva Medical Center. And the hope is once we get up and running and are busier, it'll be more frequently, twice a month possibly.
Oh, that is terrific. That's really terrific.
You know, I had a good friend that suffered from diabetes, and he did eventually lose a couple toes. And then I ran into him years later, and he had lost a whole foot. And apparently because he didn't really take care of himself, he didn't follow up.
Yeah.
And he suffered the consequences. He's passed now, but it was really sad to see him deteriorate like that, and part of it was his own fault.
Right.
Well, people have to follow up. There's no question. People are free. They can choose to or not choose to. But most people, if they understand what the deal is, what the nature of the problem is, and they know that they can get expert help with it,
Right.
they'll usually, most people want to remain as functional as they possibly can.
Sure.
Yeah. No, gosh.
And the issue with diabetics is the fact that a lot of times they don't have sensation to their feet. Over time, they can lose a lot of that. So they're not feeling, and on a regular basis, they're not thinking that they lose that protective mechanism of pain.
Mm-hmm.
So they can develop wounds and not even realize they have one. And then that starts a cascade of events that leads to further amputation. So it's unfortunate, and we see it frequently, and that's the whole point of starting these limb preservation centers, to get the word out that we're here and we can try to prevent further functional loss.
Folks who watch this segment, they've seen Dr. Milliman out here a couple of times. She's coming back fairly soon, I think. And she did emphasize that exactly what Dr. Brown is saying is that if you lose the sensation, then how do you know? So what you have to do is form the habit of examining your feet, taking precautions, just making a routine where you take precautions to protect your feet. But getting checked regularly by people who know what they're looking at is really crucial in these situations, because a lot of times you don't know. Or you might see something on your foot and think, that's nothing, and it turns out, no, it's not nothing. It's a big red flag, and if you catch it early, boy. So You know, what we're going to want to do, obviously, is make sure that our entire primary care community knows about this and knows how to get in touch with Dr. Brown and the Limb Preservation Center, and gets people hooked into this and gets these routines going. I mean, if we could really do that, if we could really, particularly with our diabetic population, get people so that they were on a track. Regularly, you see this doctor, regularly you do this. It is just going to have an impact on limb preservation in our town. It's just going to have to.
Dr. Brown, how would a patient know that they need to see you? Would the primary care doctor be the one that would make that recommendation, or?
Yeah, it's a great question, because I have such a wide range of patients that a lot of them are self-referrals. I do a lot of venous work, which entails varicose veins. So frequently we have patients coming in that they have these unsightly veins on their legs, and they want them just to be evaluated because they're concerned that maybe there's a underlying problem. Most of the referrals that I get are from primary care physicians or cardiologists, where there has been a complaint from the patient. An example would be pain when I walk, which is claudication in medical terms, and it simply means that the blood flow to the muscles of the leg, the calf in particular, not getting the perfusion or the amount of blood that it needs to be able to function properly. And then the body starts to feel, as you're walking, the pain and burning in the calf. That's one of the first signs of peripheral artery disease, or PAD. And that's a significant amount of my practice, is trying to open arteries in the legs or abdomen in a minimally invasive manner, which would be using balloons or stents to go in and decrease the amount of blockage so that the patient gets more blood down the leg.
It's very important that people realize that you don't have to get a referral from your primary care doctor. I mean, I'm sure there's people out there right now who are hearing this who can relate to this. You're somebody who's been active. You like to go to the mall, you like to walk around, go to the stores, what have you. Just take walks outside, and you notice that, boy, you get a certain distance and your legs start to hurt. Okay, if that happens, that's not something you ignore, because that's going to get worse, and it can also present with a catastrophe, where your leg just gets cold out of nowhere. And so if you're having those kinds of symptoms, sure, it's good to tell your primary care doctor about it. But if you have any question in your mind, gosh, maybe this is the thing that they're talking about, I'm not getting enough blood to my legs, you can call Dr. Brown directly. You'll be seeing, if you haven't already, you'll be seeing his telephone number come across the screen during this broadcast, and you can just pick up the phone and call his office and take matters into your own hands, which is great anyways, because then you're taking more control over your life and your health, which is what we're all trying to do. So.
And as a side note, the other important part of that is that peripheral artery disease is a systemic problem, meaning it's all throughout the body. So a significant amount of people that have claudication or problems in the blood vessels in the legs also have problems with the arteries of the heart and the neck, so that they're at an increased risk of heart attack and stroke compared to the population who doesn't have peripheral artery disease. So leg pain can be one of the first things that somebody elicits and goes and seeks medical help, and then lo and behold, you also have carotid artery disease and or coronary artery disease.
So if somebody comes to your office just out of nowhere and they had pain in their legs and they called you and came in, you would check them out in terms of the other arteries in the body where there's potential problems to make sure that they're safe.
Absolutely. Yeah, they have, full physical exam and history, and in that you can elicit whether the risk factors are they the kind of patient that needs a carotid artery duplex, which is a type of test that we use to directly look with ultrasound imaging.
Doesn't hurt, folks, just pictures.
Just a little bit of cold jelly on the neck, no problems. Takes about 20 minutes to do, and that can give us evidence right away whether or not there's a significant narrowing or plaque in that artery. And the worse the narrowing gets, the higher likelihood of a stroke occurring. So at a certain degree, we recommend medical therapy versus surgical therapy for the carotid artery.
Now, do you, if you've got somebody who's got a surgically remediable lesion, I mean, they got something going on in their carotid that needs surgery, obviously it's going to be on a case-by-case basis, but do you like to approach those minimally invasively, or do you do those open, or?
Absolutely. So, University of Florida is one of the largest vascular surgery departments in the southeast United States, and during my training I did a significant amount of carotid stents, which is a minimally invasive way of approaching
What
disease
what that means is that he isn't making a big incision on the neck.
Correct. Yeah, we go through an artery in the groin and use a catheter to kind of finagle our way up to the artery in the neck, and then place a stent in the neck, which effectively acts as a scaffolding to push the plaque away and reopen the artery with a normal size channel.
I would think the recovery from that would be pretty quick,
Yes.
if you do it that way.
Correct, yeah, the patients typically are in the hospital, they're in the ICU overnight, and then are discharged the next day.
And they're only in the ICU because you want to watch them closely.
Yes. Now, that being said, the jury is still out on carotid stents. There has been numerous studies from the stent companies marketing the usefulness of carotid stents. The carotid surgery that's been done, it's the most common vascular surgery in the world on an annual basis. That's been done for 60 years with very good results. That's the gold standard for fixing a problem like this in the neck, with a couple exceptions. For patients who are at extremely high risk for undergoing heavier anesthesia, they would be candidates for stent. So in my practice, I do the surgery vast majority of the time because it's still all things considered, minimally invasive surgery where the incision is quite small in the front of the neck. Within a month or so, you really can't even see the incision.
And an incision there really doesn't slow you down post-op. I mean, once you get out of the hospital, you can pretty much go back to normal activity right away.
Absolutely. And that's the beauty of this particular surgery, and that's why it's lasted so long, is that it works very well and it's very safe. The reason that carotid stents have not really caught on is the fact that they have not been able to match the results of carotid surgery, or the endarterectomy is what we refer to it as.
That's where they go in and they actually take the plaque out rather than compressing it. And, when you're talking about this particular problem, again, the impact, folks, the impact on your life if you avoid a stroke, or if somebody in your family avoids a stroke. It's hard to really characterize how massive that is. to be able to avoid something as devastating as a stroke.
You know,
And-
I had a friend, an older friend, that had lived next to my dad and mom, out having dinner, drinks, and everything, went home that night and had an episode with his carotid artery, and ended up having a severe stroke that left him unable to talk, walk right. Wouldn't there have been any symptoms?
If you're lucky, there may be,
Lucky.
symptoms of a mini stroke or TIA.
Mm-hmm.
The majority of the time, though, this is very similar to coronary artery disease, where the first symptom is a heart attack.
Mhm.
So your first symptom may be, if you're lucky, a mini stroke, or could be a devastating stroke.
Okay.
And these things, the doctor just referred to something called a TIA, and he can probably tell you a little bit more about what that is, but you'll notice something. If you have one of these little events, you'll notice something. Like, for example, numbness or tingling somewhere on one side of your body or the other,
Absolutely.
or
So I try to talk to my patients when we meet for the first time. We discuss, from a holistic standpoint, we just talk about arterial disease, educating them on arterial disease in general. So they may come in with leg pain, but I try to redirect and ask during the history taking portion, have they ever had symptoms of a stroke or mini stroke? Because a lot of the patients really have not been asked this, shockingly enough, in other interviews with physicians. So the main things are, like Doctor said, numbness, tingling, inability to move an arm or a leg, same side of the body, difficulty speaking. So, and this can be just for a couple seconds, couple minutes. The definition of a mini stroke is that your symptoms resolve completely within 24 hours. But they can be profound. Someone can get up for breakfast and are not able to pick up the spoon. Difficulty getting the words out. Another symptom is partial blindness in one eye, as if someone's pulling a blind down, not flex and blurry vision, but actual blindness to the upper part of their visual field on one eye. And then just general confusion, which can be a little bit of a confusing symptom. It can be multiple causes of that, but generally people having mini stroke or a stroke exhibit one or a couple of these symptoms.
What does TIA actually mean or stand for?
That means transient ischemic attack. So that would transient, comes and goes very quick, ischemic, lack of blood to the brain.
Okay.
so folks, obviously, if you have one of those, you'll notice it all right. And the message here is really simple. Take it seriously, okay? Well, it came, it went away, okay, I'm fine. No, you can't do that, because what has just happened is that you've been given a golden opportunity. If it comes and goes like that, you've been given a golden opportunity to jump on it and get it taken care of before it has a chance to be permanent.
Absolutely.
So don't ever neglect, if that happens, don't ever neglect that. And if that happens, don't wait and call this doctor and call that doctor and so on. Call him. If you have something like that happen, just get on the phone and call his office. He'll see you promptly. You want to be seen promptly, because you want to really get this checked out and dealt with quickly. So those are symptoms that doctors find alarming, and that patients should find alarming too. Just think of it as kind of like radar that's warning you of an incoming attack.
They've tried educational programs to call these brain attacks, to get the awareness of how serious some of these relatively minor, yes, they come and go, but as Doctor said, this is a very serious condition that if you are blessed and you can get it looked into, you absolutely need to.
Absolutely. Okay, that's excellent. So if you go in for one reason, that's going to be checked out too, and you can start to get a sense of the safety factor here, of having things seen early and dealt with early. Now, it's not uncommon for someone to come into the emergency room and, they're having some kind of a stomach issue, what have you, and they get a CAT scan. And incidentally, in the CAT scan, the radiologist says, whoa, your aorta's too big. The aorta is a great big artery that runs down the center of the body. It's the main artery coming out of the heart. And it's supposed to be a certain size, and you didn't feel anything, you don't know anything about it, but they just say your aorta's too big. Now, what's that all about?
And that's another perfect example of my patients have conditions that on a daily basis that they're not presenting any pain. Abdominal aortic aneurysm can be a devastating problem to have. If the aorta ruptures, there's 80% chance of death. Patients getting to the hospital and getting successful treatment and leaving the hospital is the important part. It's 5% of people. So
you don't want to let it get that far.
Exactly. The majority of aneurysms that are found are incidental findings, where exactly, perfect example, coming into the emergency room for a kidney stone or generalized abdominal pain, and lo and behold, you have this dilation of this the largest artery in our body.
Now, what actually is an aneurysm?
So, aneurysm is the dilation of this artery in the lower portion of the abdomen, where it dilates greater than 150% of its normal diameter.
Now, why would it do that?
So, the arteries in our body are muscular, and there's 3 layers of muscle that hold them together, essentially. And over time, the risk factors that haven't completely been identified, but the major ones are smoking, male gender, family history of abdominal aneurysms can predispose patients to weakening of some of the structures within the wall of the artery.
So the wall itself kind of weakens, and everybody talks about blood pressure. Well, blood pressure means pressure. There's pressure inside that artery, like inside a pipe. So if the wall weakens, it starts to expand?
Absolutely.
Okay.
Just like when you, as a child, you may have pumped up your bicycle tire too much and you got a little bleb, a little bubble on the side of the tire. Same thing happens. The pressure on the inside of the artery over time can slowly dilate this vessel. And this is a process that takes years to happen, which is the fortunate part of it. So if we're lucky and when we find a small aneurysm, we can put the patient into a program within the practice where we're looking at this on a regular basis. If it's a small aneurysm, which is defined as less than 4 centimeters in diameter, we watch that with just an ultrasound of the belly once a year. Painless study to do. Takes 20 to 30 minutes for ultrasound tech to look at the aorta with their machine and give us an idea whether or not that patient goes into a more severe or higher risk category or larger aneurysm. And once the aneurysm becomes 4.5 centimeters or so, we start to look at it every 6 months with a CT scan.
Are they removable? Or is there a way to get rid of it?
Absolutely, yeah.
Yeah.
They're so, and this is why I got into vascular surgery. It was these were as a young trainee. Aortic surgery is the big surgery that we used to do, and that's 15 years ago, you literally open the artery up and sew in a graft, a piece of material that replaces the vessel. Over the last 15 years or so, other people have developed what's called a stent graft, which I fortunately, when I was training, they were just coming about, and so I've seen these become much more user-friendly from a surgeon standpoint, where the delivery system and the way you put a stent graft into someone's belly is actually through the vessel in the leg, the femoral artery. We used to have to do an incision on each leg and try to place this plastic tube or a sheath into the abdomen through the leg. And these sheaths were the size of a Sharpie marker.
Mm-hmm.
They're rather big. Now, after a couple generations of these devices, they're about the size of a pencil. So over the last 8 years, I have had to make an incision on someone's leg one time. Otherwise, I've done it all with just needle access. So the patient comes in, hopefully elective. They have an aneurysm that is greater than 5.5 centimeters for a male or 5 centimeters for a female. And after the appropriate, see your primary care doctor, see the cardiologist to make sure you don't have coronary artery disease. We take them to the operating room and access their vessels in the leg with a needle and then a small catheter. Procedure takes typically an hour and a half to 2 hours. They go to the intensive care unit overnight. 9 out of 10 times they're discharged home the next day.
Oh, my
Man.
gosh.
So,
Folks, you have no idea. You have no idea what, in the last century, in the midst of time when I trained, okay, at Indiana University Medical Center, when I was chief resident there, we did not have vascular fellows. So the chiefs did all the big vascular cases. So I know what he's talking about. And it used to be just a monster of an operation, huge incision. And to hear him talk about needle access and an overnight stay to fix an abdominal aortic aneurysm, that's like, whoa, that's unbelievable, unbelievable that we have access to that kind of thing.
And
So-
I always thought aneurysms were in the head.
Well, they can
Oh,
be.
absolutely.
They can be.
They can
But I
be.
never realized,
Anywhere you have an artery, it can weaken, but,
Yeah.
So-
go ahead.
I'm sorry.
No, go ahead.
the most common area in the aorta, 80% of aneurysms are in the lower abdomen, just above your belly button, is where they most commonly reside. Minority of the time, they can be still involving the aorta, but in the chest, so above the diaphragm. And then there is a percentage of patients that have, and I'm sure you've seen these in training too, thoracoabdominal aneurysms, where the aneurysm involves the belly and the chest. And those are not done in community hospitals.
No.
Those were procedures that I did in training at a large university setting, where
Absolutely.
you have the surgeons who are doing these kinds of procedures on a regular basis.
That's right.
And just as importantly, you have the nursing staff that are in the recovery area and in the ICU, the resources to take care of these critically ill patients for days, weeks, or longer in their recovery.
That's right. That's
So I'm talking about the majority of abdominal aneurysms, and they can be fixed, and studies have shown this, they can be fixed in the community setting very safely. I'm, in a way, a gatekeeper where I see these patients that may have an aneurysm that's 2 inches higher, maybe a little closer to the diaphragm, where they involve some very important blood vessels. Those patients need to go downtown to the larger medical center to be monitored and then eventually, once the aneurysm grows to a certain size, to then be fixed.
Now, it might be occurring to people, well, geez, why don't you just fix it as soon as you find it instead of waiting for it to grow?
Excellent question. Yeah, so that would be the impulse, I think. But the risk of an aneurysm rupturing is very low, right up to a certain size. So the 5.5 centimeter mark that I referred to earlier for males and 5 centimeters in females, that's the number that we're looking for on these CAT scans that we get in the office.
So if it stays below that, and then you say, okay, we'll come back, we're going to recheck. They come back and recheck, and it hasn't gotten any bigger.
Yes.
So then they really don't have that risk, and they might be able to avoid the procedure altogether.
So less than 5.5 centimeters in a male, they come back in 6 months with a repeat CAT scan. And then once the aneurysm, which natural history of these things is that they slowly grow. We used to think that an aneurysm would grow 0.5 centimeter a year. And in reality, now that so many of these CAT scans are being done as an effort of surveillance, these aneurysms, they kind of have a mind of their own. They're going to have a little growth spurt, then they'll sit quiet for months or a year or longer, and then have another spurt. So that's why we're looking at them on a regular interval. And when we catch them, one that has increased in size, then we get the cardiologist to clear them and then take them for elective surgery.
I see. So the point is, folks, that if you're being watched, you're going to be safe. And he's not going to do a procedure that you don't need, but he's going to make sure you get one if you need one. And that's where this expertise comes in, of having somebody who really knows what they're doing, watching this and following this, and also, depending on the type of aneurysm, making sure that it's done in the right place for your safety.
Yes. University hospitals, as I previously stated, I moved up here from Florida, was there for 10 years in private practice, and the system that we have in place here in Northeast Ohio is absolutely amazing. With the referral pattern to the specialist like myself downtown that are doing these on a regular basis and can the hospital resources are there. It's literally picking up the phone to one of my partners and letting them know we have this, and there's no delay in the care. It's seamless.
That's UH to a T. That's the UH philosophy to a T. And I can tell you, and you know this from the shows and from the things that have happened over the years, that kind of seamless access extends all the way out to UH Conneaut Medical Center. Many times, I have people, and I see certain problems, and I know, well, that's beyond what we can do out here, but maybe it's something that can be done in Geauga, or maybe it has to go down to Case. Seamless, just like Doctor says. You had mentioned that there's work with veins that you do as well. Could you tell us a little bit about that?
Absolutely. So venous disease is kind of the third part of what a vascular surgeon does. We do arterial disease, we help patients with dialysis, and the third major part is trying to treat patients with venous disease or venous insufficiency, or what's commonly referred to as varicose veins. This is a problem that is very prevalent in the community. It's actually 10 times more prevalent than arterial disease. Probably everybody out there listening has a friend or family member that has varicose veins. This is not a condition that anyone necessarily has a hospitalization or loses a leg over or dies from, but it is a very serious condition that affects people on a daily basis. Patients can have leg swelling, discomfort when they do their activities of daily life, and just aggravates them on a regular basis. what I started in Florida was a vein center that we had for 10 years, treating patients with varicose veins. And they are the manifestations or what we see at the skin level. There's a problem underneath that, which the veins have malfunctioning valves. And these valves within the veins should be closing rapidly in between heartbeats to keep pressure very low in the veins of the leg. When these valves are not working correctly, patients can slowly develop symptoms. The vast majority of the time, patients with reflux disease or varicose veins don't have symptoms, but when they do, there's a very straightforward procedure that's done in the office where we close the vein, the saphenous vein, and can generally give dramatic relief from swelling, fatigue, and help with removing these unsightly veins.
Well, people out there, I'm sure they know what you're talking about. I mean, you can see these great big twisty veins, the varicose veins, but I think also people realize that, you know, either they or they know somebody where the lower leg is swollen, it's kind of discolored, it's kind of a dark bronze colored. Sometimes you get little ulcers there that are very tough to heal, and this points to exactly what doctor's talking about. It's not just a cosmetic problem, although that in and of itself, if you don't like the way they look, you can do something about it. But it can also cause symptoms, it can impact your quality of life, and so this is not something that you have to live with. This is not something you just have to put up with. You know, if you want help with it, you know, it's crucial that you know that help's available, that there actually is something that can be done about this, and where you get it, where you get that kind of help. And I think what doctor's talking about here is that those kind of problems are definitely something that he emphasizes.
Absolutely, and the veins that are not working correctly to give varicose veins can be easily diagnosed with an ultrasound that's painless. Again, takes about 30 minutes to do. And then once we've identified the fact that the patient has reflux, the office procedure is, again, about 30 minutes, and the patient is up and really with minimal downtime.
That's incredible. That's just amazing. See, I just learned something. I didn't realize that kind of a procedure was even available. That's fantastic. Wow, that's great. That's great.
Yeah.
All right, so that's another area that doctor covers. So in addition to the arterial stuff and the dialysis and so on that we talked about, pretty much everybody out there is going to be familiar with these vein problems. And again, you can talk to your primary care doctor about it, who can refer you, or you can call doctor directly to come in and have him take a look and see what's going on, and then tell you what he thinks and what might need to be done to help you. Well, gosh, we really appreciate you coming out here this morning. This is great, folks. I hope people with diabetes out there heard the front part of this show and know what that's about, and know that there is a center where there's real expertise in making sure that you keep your limbs and you keep them healthy. And we talked about strokes, and we talked about aneurysms, and you've seen doctor's phone number, so you know kind of some of the things to look for. You can talk to your primary care physicians about this. And this is yet again the strength of the UH approach and the UH system, that we've got specialists with his level of expertise available to our town. I mean, that's fantastic for us out here in our town. We really appreciate your coming by and being with us this morning.
My pleasure. Thank you.
Very educational. Thanks for watching. See you in a couple of weeks.